Hi, everyone. Welcome to the Lymphoma Research Foundation's What to Know About Minimal Residual Disease webinar. I'm Hope Avalon, and I'm the Senior Program Manager of Patient Education here at LRF. During today's webinar, you'll hear from an expert speaker, and you'll have an opportunity to ask questions. You can ask those at any time in the Q&A box at the bottom of your screen, and we'll address as many as we can before, after the presentation and before the end of the program. As a reminder, this webinar is being recorded. At the end of the program, you'll be prompted to complete a program evaluation. Please do complete this evaluation as we incorporate your feedback into future programming. But for now, let's get started. Thank you to each of you for taking the time to join us on today's webinar. We'd first like to thank our sponsors, Adaptive Genentech and Lilly. Before we begin with the program, I'd like to share some additional information about the Lymphoma Research Foundation. We're the nation's largest nonprofit organization that focuses specifically on lymphoma, and our mission is to eradicate lymphoma and to serve those touched by the disease. All of our work is led by our Scientific Advisory Board, which is a group of 45 leading lymphoma experts from around the country. And in addition to today's program, we also have a variety of other programs and services available for you. One example is our LRF helpline, which serves to complement our patient education programs. The helpline has master's level trained staff who provide individualized information on all types of lymphomas, as well as information on treatment options, clinical trial navigation, and connections to resources such as financial assistance. We also offer a peer support program called the Lymphoma Support Network. And through the Lymphoma Support Network, we can connect patients and caregivers with others who have been through similar experiences for emotional support. In addition, LRF has free comprehensive disease guides and fact sheets, which can be ordered or downloaded on our website at lymphoma.org. We also offer a variety of other in-person and virtual educational programs so that you can continue learning about the latest updates throughout the year. And finally, we have an award-winning mobile app called Focus on Lymphoma. The app provides helpful disease content as well as unique tools to help you better manage your lymphoma. The app is available free of charge in the Apple App Store and in Google Play. I also wanted to briefly highlight our upcoming Midwest Lymphoma Workshop. Lymphoma workshops are one-day educational programs that provide the latest information about lymphoma, current treatment options, and patient support issues. And this workshop will include subtype-specific breakout sessions where you can hear about your specific type of lymphoma from an expert. This Midwest workshop will be held on Saturday, April 6th in Chicago. And you can view the agenda and register for the program at lymphoma.org/Midwest workshop. We have a wonderful program planned for you today, and I am so honored to introduce our speaker, Dr. Loretta Nostipel. Dr. Nostipel is a hematologist and oncologist at the University of Texas MD Anderson Cancer Center, where she's an associate professor in the Department of Lymphoma and Myeloma. She's also the director of the Lymphoma Outcomes Database and section chief of new drug development. Finally, Dr. Nostipel is a member of LRF's prestigious Scientific Advisory Board. We're so happy to have her on our program today. Thank you, Dr. Nostipel. I will now turn the talk over to you.
Thank you, Hope. And I really appreciate the opportunity to kind of walk you through my perspective on MRD, describe the different modalities that are currently in use in the clinic, talk about some of the developments that may shape the future of how we approach lymphoma, but importantly, give you time to ask questions because this is aimed to give patients and caregivers that are impacted by lymphoma an opportunity to really ask any question because this is a pretty complex topic. These are my disclosures. I always like to start these types of discussions with recognizing there are at least 60 different types of lymphomas. and they really probably should be considered 60 or more distinct diseases. And so when you hear one question asked about a particular lymphoma, recognize that that could be a very different disease than someone else, even though we use an umbrella term of non-Hodgkin lymphoma that lumps everything that's not Hodgkin's into one sort of unified description, even though, again, these are vastly different diseases. Now, they all arise either from B cells, T cells, or other types of white blood cells that, when behaving normally, fight off infection. So that's how we characterize these different cancer types. And again, recognize that they have very different approaches, they have very different expectations. But today I'm going to spend most of the time talking about where MRD may be applied in CLL, SLL, follicular mantle cell, and diffuse large B-cell lymphoma. So what is MRD? So I'll describe the definition, which is minimal residual disease, and the various tools that allow us to detect minimal residual disease. We'll describe the clinical scenarios where it's currently applied, and then again, describe where it might be utilized and which tools might be applied in the near future. So I'm going to start by putting this into a clinical context where I think MRD would be incredibly helpful. And this is a real patient of mine. It's a 56-year-old male who initially presents with abdominal discomfort. In addition, he's got fatigue and quite a bit of weight loss. And when he's assessed by a clinician, is found to have a pretty large abdominal mass, also a left groin mass. This leads to a biopsy, which reveals diffuse large B-cell lymphoma. And even if we think about the breakdown of large cell lymphoma, there's a lot of different clues that help us distinguish the 19 different types of diffuse large B-cell lymphoma. But it is a germinal center-derived B-cell. There's description of sclerosis on the path report. And FISH was done that shows that there's no rearrangement of MYC or BCL2. So this is not a double hit large cell lymphoma. Imaging reveals this patient has lymph nodes that are abnormal above and below the diaphragm. The largest mass is a mesenteric nodal conglomerate. That just means there are lymph nodes that have gotten so large that they're now sort of merging together, and it's hard to distinguish individual lymph nodes. But if you measure the cross dimensional direction, it's 13 centimeters in the longest diameter. And the SUV, which is the intensity of the sugar uptake in this mass, is 20. So this is a snapshot of that PET. So you can see again that this is a large abdominal mass. And it's essentially several lymph nodes in a chain that have all kind of grown together. In addition, some groin adenopathy. So this patient gets standard of care R-CHOP at the time. So this is not a case that I've seen today or right now, which you could make the argument for polatuzumab, which is an antibody drug conjugate in combination with rituximab and CHIP, based off of the POLARIC study that suggests that might be a better option than R-CHOP. Nonetheless, after 6 cycles, you can see the PET shows that there's no measurable disease anymore. So we were all very excited. This large mass is now resolved. You can see there's no abnormal uptake now in the middle of the abdomen. Similarly, the groin has resolved. So technically, we call this PET a complete response. However, within a year, repeat PET shows that in a similar location, we now have a recurrence of what looks like the same large B-cell lymphoma. And so that's a really disappointing scenario and unfortunately too frequent. And so we always have the discussion, well, what happened? Did it really go away and then come back in the exact same place? Or was it just so few cells at this scan that we just couldn't detect it? It was below the minimal detection point. And so I generally tell my patients that to see something on a PET, we need generally about 2 million cells in one location to pick it up. And so if it's less than that, then we're not going to see it. And so again, if I had a tool that told me, yes, this PET looks good, but actually there's still minimal residual disease that I can't pick up on this PET, maybe we won't be quite so devastated whenever we see this PET that now the lymphoma is back. So again, what is the definition of minimal residual disease? So it is a tool that helps us detect disease that's below the threshold of what an imaging modality such as CT or PET can detect. And it has been shown to help us predict relapse and can also tell us which patients are likely to have a favorable prognosis, meaning they're likely to do very well, versus those that are having unfavorable prognosis. The problem, though, is you're going to see a lot of terminology, and I may even use some today, where we describe MRD differently. And so, again, think of this as just a tool to measure different depths of disease. And so you'll hear MRD negative. That's just below the detection of MRD. So just like you can get below the detection of a scan, you can get below the detection of MRD depending on what threshold you're using to look. And so that may not necessarily mean that there's absolutely no tumor cells present in the body, but it just means that the MRD is undetectable. You could have MRD positive disease where, again, these are three different patient scenarios. This green scenario, this patient has no detectable MRD and no detectable disease on imaging. So we think that patient has a very good chance it has no residual tumor cells in the body. This middle patient, you can't see the disease on CT, but also it's below the threshold for MRD detection, but over time that changes. And now we see in this period of time, you can detect the MRD, but you can't pick it up on imaging. And eventually it's true for both. And then you see patient 3 scenario where, again, the amount of disease is below the detection of imaging, but still detected by MRD tools. And again, those patients are more likely to progress sooner. The other way that you could potentially use this is not only looking for quantity of tumor over time, but also being more confident in negative scan that these patients are not going to relapse. Because I think that's the hardest part is we're always sort of managing expectations and dealing with probabilities. And so we tell folks that there's a very high likelihood of cure, but we're never fully confident. And so if you have a patient that has a molecular remission, meaning no detection of MRD, and we can't pick it up on imaging, we're much more confident that those patients are not likely to relapse. There are different ways to detect MRD, and one of the earliest was done by flow cytometry. So what is flow cytometry? This is where we take a liquid sample, usually either from the blood or from the bone marrow, and we take these cells and we mix them with fluorescent labeled antibody. It's what these upside down Ys are. And you can see the little antibody that's labeled so that we can detect color in a specific machine or laser beam. And then we run these cells individually through this tube, and the laser can detect this fluorescence. And then using various forms of magnetic charge, you can separate these cells that have certain proteins on the surface into individual sort of wells, and then you can quantify them. So it gives you essentially two important pieces of information by looking at each individual cell in that sample. So you're really just quantifying of those cells, which usually start with 100% of the cells present, what percentage has these features? And so it helps you look at quantity, but it'll also help you characterize those cells. And so again, all the cells in this well are going to have this protein that we have been searching for with this fluorescent dye. And then again, you can make a diagnosis of disease such as CLL, mantle cell lymphoma, just by running flow cytometry. You can also determine how much of the given sample has those cells present. And again, CLL is one of the first places where we've been applying this form of MRD measurement. Now, the important thing to recognize is there are flow where you look at less than 4 colors, or you can look at PCR where you get much lower quantity because you can amplify the specific sequence that you're looking for. So if it's in even a tiny amount, you can amplify it so that it's at a quantity that you can detect. Or you can look at next generation sequencing, which I'll spend a lot of time talking about, and you're just looking for the quantity over time. So if you have a CBC and you see abnormal lymphocytes, that means the pathologist can detect this with their naked eye when they look at these cells under the microscope. If you're using flow cytometry, and again, you're looking for essentially 4 different surface markers, again, you can detect a quantity that's below what the pathologist can see with their eye, but still not quite as sensitive as if you're using PCR metrics. And then even more sensitive is when you're looking for specific genetic alterations over time. And we know that for patients who've had chemoimmunotherapy, either in the form of bendamustine rituximab or fludarabine-based approaches, for those patients where MRD is not detectable, those patients are more likely to have a longer remission or progression-free survival, meaning they're more likely to live longer and have less likelihood of relapse over time compared to those patients who still have detectable minimal residual disease. Now, again, this is independent of CTs or PET scans that we generally use to tell us if patients are in remission or not. So again, prognostic. We also know that it can be applied in the era of targeted therapy. Now that we're moving away from chemoimmunotherapy in CLL, we will frequently utilize MRD to tell us if patients are likely to do well for a longer period of time. And that's in the era of BTK inhibitors, BCL2 inhibitors, etc. And so again, these Kaplan-Meier curves just show the percentage of patients starting at 100 over time, and this is in months. And those patients that have undetectable MRD, 10 to the minus 4 versus low level. So you can still pick it up, but not quite as large a quantity. So between 10 to the minus 4 and 10 to the minus 2, or those that still have detectable MRD. And again, over those patients that have a lower level of MRD detection are more likely to have longer remission periods and even longer survival. And so if you think about it, it's just a way of looking at the depth of remission beyond what we can see with our eyes, either on looking at a blood sample under the microscope or with imaging modalities. Now, again, flow cytometry is pretty easy to run. Just about every lab in the country can do flow cytometry, but it's not quite as sensitive as if you use PCR. So what I mentioned with PCR is you're looking for a specific sequence. And generally, you're looking for a sequence of genetic material that is unique to the tumor that you're tracking. And then you're going to take that sample, you're going to put it in a machine where you're going to amplify that sequence that you're looking for. So it's kind of like having a probe. And if that probe detects that sequence, you're going to multiply that multiple times so you get a larger quantity in that sample. And then again, you can look at that over time. And so that helps us be much more specific and sensitive because you're looking for a specific feature of the tumor cell, and you can get to much lower levels of detection because you're going to amplify it in the tube so that you have a much higher chance of actually capturing that tumor sequence. And there are next generations of this. So again, looking at various formats of PCR, you're going to have a greater likelihood of detecting a very low quantity. Now, there are obviously advantages and disadvantages of the different methods. qPCR is the one I described, which has been most commonly utilized. ddPCR, droplet density PCR, is something that we're moving towards, mostly in research questions or protocols. And then the next generation sequencing, where you're looking specifically at the immunoglobulin region. So all B-cell lymphomas generally are going to be able to be distinguished from other normal B cells based off of their surface receptor. And if you can sequence a portion of that receptor, then you can just look for that sequence of DNA over time. So this is going to be much more sensitive than PCR or ddPCR, but it's going to be a little bit more intensive in terms of turnaround time. It's going to be more expensive, and it is not standardized across a number of labs, meaning this is generally not something that you're going to run in-house. You're going to send this out to a third party. But again, looking at MRD via either PCR metrics can be done in peripheral blood or bone marrow, and it can be clearly prognostic. So once again, those patients that are MRD detectable versus MRD undetectable, you're going to have differences in outcome, suggesting that our goal may be that we achieve MRD negative or MRD detectable because those patients are more likely to stay in remission. Then the question becomes, well, when is the best time to look at this? Should be at the end of 6 cycles of treatment, or what if patients aren't responding? Do you really want to expose them to 6 cycles of chemotherapy before you decide to reverse course? So those are some of the research questions that I don't think we've fully answered, but clearly at the end of treatment, those patients who are MRD undetectable are going to be in remission much longer than those who still have detectable disease. Now, it would make sense then if you have a tool that can detect very low quantities of disease that can help us, particularly when the imaging modality is not quite as sensitive. Why not do that at the end of treatment and then determine who needs additional therapy, such as maintenance treatment? And so that was the question that was potentially asked and answered in this Italian study, where they took patients with follicular lymphoma and they used PCR looking for the translocation 1418, which is the hallmark of follicular lymphoma. And so then at the end of treatment, those patients that were negative, at that point they were considered to do nothing or maintenance rituximab. Those that were positive all received maintenance therapy. And really the take home, which is kind of complicated from these curves, is that patients who are MRD negative, you would think that that would be an indication to just stop treatment. They don't necessarily need to proceed on to maintenance. But interestingly, those who are MRD undetectable and received additional maintenance therapy actually did even better than those who we tried to modify that outcome by adding additional therapy in. So I would say the challenge with PCR currently is that it's probably not specific enough, even though the sensitivity is better than a scan. It currently does not provide us the tool set to be able to say, well, these patients need less therapy than others. But again, can help us predict the future in terms of who's more likely to do well than others. So I think where we're actually headed in this field is looking at circulating tumor DNA, or what we call liquid biopsies oftentimes. So what is that? This is where we actually look in the peripheral blood or in the bone marrow, anywhere where you have a liquid sample, and we're looking for specific components of DNA that's been associated with specific cancer. So this is not unique to lymphoma, and actually in other disease entities such as multiple myeloma, colon cancer, etc., I would say they're probably even further along in advancements than we are in lymphoma. Just looking at specific mutations or specific fragments of DNA that we know is associated with specific tumors, and then looking for that quantity, suggesting that if it's present, then maybe that's coming from DNA from the tumor that's being shed into the blood. And not only is it present, but then what is the change in quantity over time? And sometimes we also see changes in the disease mutation. So for instance, P53 is a mutation that commonly will become more frequent over time, particularly in patients with, say, CLL or mantle cell lymphoma. So you could also look at the dynamics of the disease and how that may change over time. So there are a lot of advantages in this, because you can look at quantity similar to flow cytometry or PCR, but you can also look at qualitative changes, meaning what is changing with the tumor and how does that then inform how we might modify our treatment approach. And so that's what this slide essentially shows. So I do think there is more enthusiasm regarding circulating tumor DNA for those properties. So again, you could potentially even use it as a diagnostic maneuver, because you can look at mutations that are commonly associated with the disease. And a great example of this is there was a study done looking at pregnant females, taking a blood sample and then analyzing it for genetic mutations that might be associated with the fetus, because pregnant women will have DNA in their blood from the baby that again sheds and is picked up in blood, very small quantities, but then you could then spare them from having an amniocentesis, where you essentially draw fluid out of the sac where the baby is contained. And so that would be a tremendous advance. You could also potentially tell the sex of the baby. So that was very intriguing. But what was also quite intriguing is they actually found mutations that identified patients that had Hodgkin lymphoma, which again, very infrequent scenario. But that was a very interesting discovery. And so you could then sample the blood and look for specific mutations associated with specific cancers. That doesn't currently spare you from having to go on and biopsy a lymph node, for instance, in lymphoma to be more precise, but another application of something like circulating tumor DNA. Then you could look at the change over time and quantity. So that's where you could potentially pick up that MRD detectable disease that's beyond the scope of what the scan can pick up. But you could also see where some of the changes in the tumor biology occur over time. So one of the theories as to why patients will go completely in remission, that scan I showed you where all the disease disappears, but then over time it emerges again. And a couple of theories is that you actually get rid of the cells that were sensitive to chemotherapy, but the few cells that were not over time become the dominant clone. And so that's where circulating tumor DNA could help you, because not only could it predict the chance of relapse, but can also identify specific features of that tumor that may change over time that may help us predict resistance to specific therapy. Again, what are the potential advantages and disadvantages of PCR versus next generation sequencing, or what are some of the examples of next generation sequencing? I would say the general consensus is that the circulating tumor DNA is going to be much more sensitive. It also allows you to genotype, which is describe the genetic changes in that tumor over time. And obviously, it's going to give you a little bit better tool in terms of monitoring over time. Now, what are the limitations? Well, it can be quite expensive. The processing of the blood samples, the quantity of blood over time, it's much more complicated, in my opinion, than PCR or even flow cytometry. And I'll walk you through some of the data that currently exists, but clonoSEQ was one of the first modalities that was approved for use by the FDA, and they're essentially looking at the sequence of the immune globulin and tracking that DNA sequence over time. You could utilize CAP-seq, which was first done actually in lung cancer, where you can look just at common mutations with a given disease in the blood over time, where you don't actually have to sequence the tumor. So it's kind of non-specific to a given patient's tumor, but looking at mutations that are known to be associated with a disease and quantify that over time. And then phase-seq is one of the most recent applications of CAP-seq, but it allows the detection quantity to drop dramatically lower, and that's why the sensitivity value is so much greater. And then whole exome sequencing or whole genome sequencing is where you actually sequence the tumor and look at all the coding regions or look at all the coding and non-coding regions, look for that specific sequence over time. And this is actually much less sensitive, and it's super expensive. So that's not really a feasible strategy. Okay, so where is circulating tumor DNA currently being applied into practice, and where is it headed? Well, we do know that circulating tumor DNA has been applied in large cell lymphoma for patients in frontline, meaning those who've had frontline treatment. And this was an analysis looking at cycle 3, day 1, where we commonly will get what we call an interim PET, which is patients have 2 cycles of treatment. They're coming in for their 3rd cycle. They have a PET scan. We're usually looking for signs that the treatment is not working. And you can also look at a blood sample at that time and look at the circulating tumor DNA. And what this study showed is those patients who have circulating tumor DNA that's not detected, or ctDNA negative, the vast majority of these patients stayed in remission, meaning they never relapsed, looking as early as cycle 3, day 1, so even before they finished the full 6 cycles. However, for the patients who had detectable circulating tumor DNA, which again, we would not be grossly disappointed at a PET scan at cycle 3, day 1 if there was still some measurable disease. But if you look at the MRD, that might tell us that though some patients do well, the vast majority are going to have much higher risk for progression of it. Again, that's an early look at the dynamics of the disease over time. You could also look at how does this correlate or associate with overall survival. So not only is it undetectable or detectable, but looking at the degree of change over time. So a 2-log drop, for instance, was associated with more favorable survival. And so this is an early, so again, even prior to cycle 2. And then this is a major, so the depth of change over time. So again, looking at various characteristics of that circulating tumor DNA. So again, it helps us risk stratify patients, who's likely to do well, who's likely to going to do poorly, but there's still some limitations of this test. So you, again, have these down ticks in these curves suggest that some of these patients still had poor event despite being negative by circulating tumor DNA. And if you look at these ticks on this curve, so these patients have detectable circulating tumor DNA, but they have not had an impact on their survival. So How do we interpret that? So that tells us we just need to have a little bit better tool, because these are probably false positives and these may be false negatives. But again, here's an example of how you could track this over time. So this is a patient with large cell lymphoma, gets frontline treatment. So this is before they start treatment at cycle 2, day 1. You can see the interim PET has clearly become negative, meaning there's no measurable disease. And you can also look at these specific mutations that have been tracked. So they were detected at baseline. They dropped down to sort of almost undetectable or near baseline, stay low. So this finishes the end of treatment PET. Patient is now undergoing surveillance, so they're coming in generally every 3 to 6 months for the first year, and then every 6 months thereafter. And you can see that their first surveillance scan, everything still looks good, but now you start to see changes over time. But not only do you see an increase in the detectable blood volume of disease, but you also see a change in the mutation profile. So for instance, again, you're not seeing any change in the this specific mutation, even though it was detectable at baseline, whereas some of these other mutations are becoming much more pronounced over time. And it's really at this point where it's detectable in the blood sample, it's really not till the imaging at this point, when again, the blood samples are much higher, where you start to see it actually on imaging. It could also help you at the end of treatment in predicting the future for patients. So these are patients with large cell lymphoma who had phase-seq. So I mentioned this is one of the newest tools that they've really tried to improve the sensitivity of the test. And so this is really kind of interesting. So the patients who were undetectable ctDNA by phase-seq at the end of treatment, so they finished 6 cycles of therapy and now they're just being monitored, none of these patients have actually relapsed. And if you look at the patients where the circulating tumor DNA was positive, again, the vast majority of these patients have relapsed, with, again, these sort of rare exceptions down here. So they've gotten better. So now the negative predictive value, meaning a negative test, is very, very valuable. You don't see any false negatives in here. Still have a few false positives, but again, the test is getting much more specific. Now, what about a PET that's negative? What happens to those patients? So the patients that had a PET CR, meaning their PET was negative, they're followed over time. And again, those that had circulating tumor DNA that was undetectable did great. Only one of these patients in here and one here had an event. But what's also very interesting is the patients who had an end of treatment PET that was negative, that we would be celebrating. Actually, if they had circulating tumor DNA detected by phage-seq, the vast majority of those patients actually progressed within the first 2 years. So again, a very useful tool if it's positive, also very informative if it's negative. Could you use it to predict those patients who are going to have a CNS relapse? This is a huge area of debate in large cell lymphoma. How do we prevent CNS recurrence? And so oftentimes we discuss or debate giving chemotherapy into the spinal fluid as a prophylactic strategy, meaning we use that as a tool to reduce the chance of relapse, though most of the data suggests that that may not be an effective strategy. And we don't have a consensus on which patients should have it and who should be spared that. But what if you could use circulating tumor DNA in the spinal fluid to know who's at risk for recurrence, and maybe tailor our treatment mostly just to those patients as opposed to those who are ctDNA negative, spare them the side effects of treatment, for instance. And so that's essentially what they showed here. Very small numbers, but nonetheless, those patients who are MRD positive were much higher risk for CNS recurrence than those that were MRD undetectable. And you can make a strong argument for those that are MRD undetectable that they really should not be subjected to intrathecal chemotherapy. What about our modern therapies? Because all of those studies I've just showed you were in the era of chemotherapy. What about now in the relapse setting where we have bispecific antibodies, and one specifically epcoritamab, where patients are treated until progression or intolerance? So that's chronic therapy now, whereas always in the past we had fixed duration of treatment in large cell lymphoma. So this is data looking at MRD status in patients receiving epcoritamab. And again, very different outcomes for patients, those that were MRD positive, many of which had relapsed and relapsed early within the first 12 months, versus those that were MRD undetectable, the vast majority still remaining in remission. So we've started asking the question, could you use a tool like this to feel confident about stopping therapy in these patients that are MRD negative? And for those that are MRD positive, should we then be pivoting and going on to alternative therapy because we know these patients are going to progress quickly? Can we use circulating tumor DNA post-CAR T-cell therapy, for instance, to know which patients are likely to relapse? Because the most nerve-wracking time period for me and my patients is between day 30 and day 90. We do know that for the majority of patients who are in a remission at day 90, those patients are going to stay in remission, but there's a lot of patients or a lot of change in the remission status between day 30 and day 90. So many centers are opting out of doing any imaging at day 30 just because it's so hard to know what to do with that information. So what if we had a complementary or a better tool such as circulating tumor DNA that would help us know which patients are likely going to stay in remission versus those that are likely going to convert with progressive disease? Because I think that would be incredibly helpful in shaping our conversations and our risk approach. So not surprising, those patients who had lower levels of circulating tumor DNA, even pre-CAR T, were more likely to do better. So another way you could use circulating tumor DNA to try and reduce the risk of CAR, you could identify those patients who are likely going to do well and less likely to have toxicity. I think we would all see an uptick in the utilization of CAR T-cell therapy, just given how expensive it can be. And so this is an example where you could even just look at the circulating tumor DNA prior to CAR and be able to predict those patients likely to do well. I think it would also be helpful for those patients who have a complete response to bridging therapy. Currently, we take all of those to CAR, and we tell patients, well, we assume there's some low-lying amount of disease. We just can't pick it up with imaging. But if you knew that there was circulating tumor DNA there, I think we'd all feel much more confident about proceeding with therapy that could potentially have some toxic outcomes. Could we look at MRD and PET to, again, predict the outcomes post-CAR? And so that's what these curves show. The blue line are those patients who are MRD negative. The green line are those that are PET negative. And then the red line are those that are MRD positive. And then the gray line are those that have a PET that's not a CR. So again, the probably greatest value here is for those that were MRD positive in terms of predicting the future. And lastly, again, could we use circulating tumor DNA just in the patients who have a negative PET, or the PET is either PR stable disease at day 30 to predict the future? As I mentioned, that's probably the most nerve-wracking point. We do know some of those patients who are in a PR are going to convert to a CR, though it's the minority. We know that, but because of that, we oftentimes will just observe those patients. But again, if you had a circulating tumor DNA and assay and that said those patients are going to do well, I'd feel more confident observing those patients. Whereas if they still had detectable MRD by circulating tumor DNA, I'd feel much more confident to take those patients onto additional therapy. So that's all the data in large cell lymphoma right now. Again, most of it is done in the setting of a clinical trial. It's not commonly used as part of standard practice, but a number of clinical applications that I think in the future we could see more use. What about in other disease? One challenge actually is in indolent lymphoma, and the classic example of follicular lymphoma. The sensitivity of circulating tumor DNA is not quite as good. So here's an example of looking at clonoSEQ, which is where they look at the sequence of the immune globulin and then track that specific sequence over time. And you can see here, there's not really a clear pattern. It's kind of hard to predict who's likely going to do well versus who's likely to do poorly. And I think part of that is just, it's probably just not sensitive enough. And that's likely just due to some of the disease characteristics. So indolent lymphomas are less likely to shed tumor DNA into the peripheral blood as opposed to aggressive lymphomas. And that's just based off of the fact that aggressive lymphomas are oftentimes growing so quickly that they sometimes outgrow their own resources and will actually have some tumor cell death, and then that leads to shedding of that DNA. Whereas with the indolent lymphomas, they generally grow much more slowly, and so then you just have less of that circulating tumor DNA making out into the bloodstream where it can be detected. Could you improve upon that with a more sensitive assay? And one example is CAPSEQ. And probably the answer to that is yes. But again, in general, it's still going to be much lower detection levels than with large cell lymphoma. But what's really intriguing is you could potentially use circulating tumor DNA to look at those patients that are on the way to transformation, where the follicular lymphoma then transforms into diffuse large B-cell lymphoma, just by looking at the various mutations and how they change over time, and looking at mutations that are much more frequent with follicular as opposed to large cell lymphoma. So that would be an intriguing application of circulating tumor DNA. And similar to large cell lymphoma, you can actually track the disease dynamics over time. So these are all individual patients that start off at baseline, and then you're just tracking the circulating tumor DNA and comparing that to PET. So this is a great example of a patient that was PET negative and MRD undetectable, and that patient did well for a very long time. Here's an example of a patient that was PET negative, however, the MRD was detectable, and eventually it was discovered on PET at a later time point. This is a patient that was never undetectable on MRD, but the PET was sort of ambiguous. They couldn't tell if the patient was in remission or not. And so utilizing circulating tumor DNA would have been very helpful to interpret that PET, and a perfect example of someone who had transformed. So just different examples. But another interesting application of circulating tumor DNA is diagnosing follicular lymphoma even before it is obviously follicular lymphoma. And so backstory there, translocation 1418, which is the hallmark of follicular lymphoma, is present in about half of healthy individuals if you just look for it. And so it, even though is commonly utilized for PCR methods to track MRD over time, it's not a diagnostic maneuver. But what if you did circulating tumor DNA and actually look at the mutations that are associated with follicular lymphoma, not just the translocation 1418? Could you actually diagnose those patients who are going to develop follicular lymphoma? And so this is an example of yes, you can. So this was a very large cohort of healthy adults, about 500,000. They first looked at those patients who had detectable translocation 1418, and then looked at specific mutations, and they were able to identify the patients that actually developed follicular lymphoma as opposed to those who did not. And they also described the mutations that led to the diagnosis of follicular lymphoma, which essentially was CREB-BBP. And so here's a prime example of a patient who actually did have a scan 8 years before the diagnosis of follicular lymphoma. And about 6 years previously, they had the detection of the mutation that ultimately was associated with the development and the diagnosis of the disease. Now, the question would be, knowing 6 years earlier that you're likely to develop a disease where we don't have an intervention that would prevent the development, is that a helpful tool or a harmful tool? But nonetheless, I think it is an interesting application, particularly in a disease where we have no mutations that can be tracked in the blood over time. Well, what about mantle cell lymphoma? Again, similar to CLL, oftentimes these patients will have cells that are out in circulation, and so you could track it quite easily, either with flow cytometry or with PCR measures looking for translocations that are unique to mantle cell lymphoma. And so here's an example, again, just in terms of prognosis. It can tell you if you're going to do better or worse. And those that are MRD undetectable have better progression-free survival than those that are MRD positive. And when you look across various treatment modalities, including chemotherapy, end of transplant, generally speaking, being MRD undetectable is associated with favorable outcomes, sort of independent of whatever modality you choose. But where it probably has the greatest application is for patients that are being monitored post-stem cell transplant. So the Nordic group has been studying patients with mantle cell lymphoma for many years, and they have a very homogeneous approach to mantle cell lymphoma, which is unique because you could go to 4 or 5 different places in the US and get 4 or 5 different recommendations, and that's not wrong. Whereas in the Nordic region, all of the patients are very consistently approached with the same therapy based off of age and disease characteristics. And then, so young, healthy patients get intensive chemotherapy, and then they're consolidated with high dose therapy, auto transplant, and then they're followed over time. And what they've been doing is they follow the MRD post transplant. And so those patients who are MRD negative, they do well, they continue to follow. But for those that are MRD positive, so again, the blood picks it up, but the imaging has not. Oftentimes, they'll use that information to then act. And generally, what they'll do is they'll initiate rituximab maintenance or extended therapy to improve those outcomes. So again, a very interesting way of utilizing MRD post-intensive therapy to identify those early relapses and potentially intervene. And so that's an example of a prospective study that's underway where they'll use MRD to determine whether to escalate or de-escalate therapy. And so patients essentially get induction, their baseline and MRD status is followed. And for those that are MRD undetectable, they're then randomized to auto transplant plus rituximab versus just rituximab maintenance. For those that are MRD intermediate or they have PR, they automatically go on to intensive therapy. And then similarly, those that are MRD positive, whether or not they have PR or CR, again, similarly going on to auto transplant plus rituximab, and then MRD followed post transplant to further guide therapy. Similarly, the Dana-Farber group is using MRD to determine the duration of targeted therapy. So these are patients that are not appropriate for intensive therapy, like stem cell transplant, either due to age, comorbidities, or P53 status. They get a targeted approach with a triplet of acalabrutinib, a BTK inhibitor, venetoclax, and obinutuzumab, and then based off of response and MRD status, that will determine the duration of treatment. And again, this is, I think, probably one of the most appropriate applications of MRD, because we know those patients that are MRD undetectable are going to do well, and that may help us have more time-limited therapy as to continuous treatment, particularly with these targeted therapies that are viewed to be well tolerated, but over time we know can lead to some toxicity. So in summary, and we'll give you the last 15 minutes to ask the questions that are important to you, I do think that MRD can be used for detection and tracking of disease, and right now is currently used in CLL and mantle cell effectively. However, the tools that are currently used in CLL and mantle cell, there are some challenges, particularly sensitivity and specificity can sometimes also be challenging. It is currently used to help us understand prognosis, meaning who's going to do well versus who's going to do poorly, but we're not commonly using it to inform treatment, meaning we don't currently say, based off of this information, you stop therapy or you change therapy, but that could be a future direction. I think cell-free DNA or circulating tumor DNA appears very promising because you're going to improve the sensitivity and specificity, but it could also provide clues to the biology and how that changes over time. But the challenge is, again, particularly in indolent lymphoma, we need to improve sensitivity, maybe even in large cell you can make that argument. And we do see that is pushing technological advances that will help address this problem. And a current example is phase-seq, but others are currently underway. So where do I see this headed? I do think that we will start to see more studies using this to de-intensify therapy, meaning stop therapy early for those patients who are doing well to potentially spare them toxicity, or maybe even changing treatment soon, as opposed to waiting until you finish all 6 cycles. We could use an interim MRD assessment to then pivot and address disease that's not really easily detectable by imaging, but is clearly going to emerge as the more dominant clone. So with that, I'm happy to stop talking and then answer any questions.
Thank you so much, Dr. Nostapol. I think that was an excellent overview. We definitely have some questions here, so we'll jump right into them. Starting with the first question. If you've finished 6 cycles of R-CHOP for DLBCL and you're deemed to be in remission by your oncologist, do you recommend getting tested for MRD? And how and in what way do you initiate the conversation with your oncologist?
It's a very good question. And again, currently, right now, we're not commonly doing this outside of a clinical trial, but I still think it's worth discussing with your oncologist. Um, in general, the probably the best time to talk about it is even before you start treatment, so that you have a baseline assessment and you can assess the change over time. But don't be disappointed if they respond to your question with, well, that's not quite at the level of rigor that we're commonly applying it. I do think there are some advantages in terms of predicting the future. And I think for most patients, that's what they're looking for. And if you're MRD undetectable, that's going to be great news. I think the real challenge, though, is if you have MRD detection and your PET is negative, then how do you use that information? And right now, we don't currently know.
Thank you. And can you discuss the data with regards to ctDNA in patients post-transplant for DLBCL versus post-CAR T? I've been told data is better for CAR T, but less so for ASCT.
Yeah, that's a good point. And yes, we do have data in both scenarios. And I did show you the data post-CAR, but I left out the post-transplant just because we're doing fewer transplants these days. But in general, it's going to be prognostic in both situations. Where it's probably better for CAR T is it is informative even pre-CAR infusion, meaning if you have detectable ctDNA even prior to CAR infusion, that's going to be prognostic. And then clearly post cell infusion around day 28, that's going to be prognostic. Similarly, with auto transplant, it's going to be prognostic. I think the challenges there is trying to understand if the product itself is contaminated with circulating tumor DNA and how does that impact your desire to move forward. And then the post auto transplant surveillance maneuvers, would it be helpful to pick up an early relapse where then again you could pivot to CAR? And so that's where there are some limitations. And then the other thing that you have to account for is that we evolve over time, meaning our practices evolve. And so because CAR T is just more modern, there's more of the CAP-seq, phase-seq data emerging in the post-CAR space, whereas with the auto, a lot of that's going to looking for the sequence of the immune globulin, and not that one is clearly better than the other. We don't know that, but we do at least know that the sensitivity and the specificity might be a little bit higher with the CAP-seq or phase-seq approaches. And so again, you have to account for just that difference in era and when it was studied.
Thank you. This next participant writes that they have indolent MCL and were treated with BTK inhibitor and venetoclax. And they want to know how you would view a clonoSEQ test that showed MRD negative in the peripheral blood, but MRD positive 188 sequences in the bone marrow. The scan was MRD.
Yeah, good question. And as I mentioned, you can test MRD in different compartments, peripheral blood, bone marrow, and it would not be entirely surprising to have differences in outcome in those different areas. And that's why it becomes incredibly challenging to know how to use that information to then refine our treatment. Again, from a prognostic standpoint, it's good news that it's negative in the peripheral blood, less good news that it's still positive in the bone marrow. But would you approach that differently in terms of treatment? I don't actually know the answer to that. What I generally tell my patients is that in most all of our bone marrows are made in the bone marrow. Some will traffic out, some stay behind. Diseases like MCL, CLL, you're going to have much higher likelihood that the disease is still in the bone marrow if you sample it. And so it just may be the fact that you're going to the source when it's positive in the bone marrow versus looking for the downstream. And that would just tell me that there's a very low quantity of disease, but still detected in the marrow.
In order to track transformations over time, are new biopsy samples required, or can it be done just with new blood samples?
In the future, we would love to say that you could do it just with blood samples, but currently we are doing it with biopsies. Now, sometimes we can't biopsy a lymph node if it's in a location that's hard to get to, or it's deemed to be unsafe, or we get a tiny sample because it was a hard location, and then you're still kind of stuck with, well, it could be follicular, it could be large cell, we don't know. And so we still do sometimes use some clinical clues in addition to the biopsy or the circulating tumor DNA, and those are LDH, calcium, and B symptoms, meaning weight loss, night sweats, fever, etc. And so that's where having in advance over time is that we would use a blood sample and we would do serial sampling, and that would clue us in. But as of right now, because we're not routinely doing it as part of surveillance, I would say that right now it's mostly going to be determined by biopsy. But hopefully in 5 years, that will not be true.
Thank you. At what point and how often should a CLL patient be tested for MRD?
That's a really good question, and we're all struggling with that. So it depends. When is it most useful? It's most useful in the setting of treatment. And so particularly venetoclax-based therapy, most of their studies use MRD, and so we have probably the best totality of data in that scenario. And so for patients who are getting venetoclax-based therapy in the relapse setting, the duration of treatment is longer versus those that are getting it up front, where it's only 12 cycles and then we generally stop. We're not currently using MRD to really tell us when to stop versus when to continue. We still generally follow the protocol, but it clearly can be prognostic. In terms of for those patients who we know at diagnosis, you're going to be MRD positive because we know you have disease. And then if we're starting treatment, that can be helpful over time. But if you're just doing surveillance and we know you have active disease and we're just waiting till you meet criteria for treatment, I don't know how helpful MRD determination is at that point, though I've seen it done quite often. So I would say in my practice where it's the most useful is when we have patients on a targeted therapy and we're stopping treatment and we're wanting a glimpse as to what the future holds.
Thank you. Considering the scenario of a relapse for a patient showing complete response, would a positive MRD test lead to prophylactic treatment? If so, what kind of treatment? For example, for a DLBCL patient with complete response after R-CHOP.
Yeah, so there are a number of trials that are launching right now. So I'm hoping that we will have the answer to this in the next few years. But as of right now, we are not doing anything differently. The studies that are launching are looking at taking that patient and either giving them CAR T or a bispecific antibody, or maybe even a targeted approach to see if you could then take that patient who has a molecular relapse, but not an obvious relapse, and get rid of that clone before it ever becomes an obvious relapse. But those trials are just now launching, and there's actually quite a few challenges to how you design that study. And in the absence of a randomized trial, it's going to be a little challenging to interpret those trials as they start to read out. So it may take longer to really know how to apply that information. But I suspect, again, in the next 5 years, we will be doing just that.
Are there any studies looking at ctDNA and overall survival for DLBCL patients undergoing bispecific treatment?
Yes, I did show you one example in patients receiving epcoritamab. They've been tracking MRD, and the patients who are MRD undetectable do far better than those that have MRD detectable disease. Similar studies have been done with glofitamab, which is the other CD20 bispecific antibody that's currently FDA approved. And I will say that essentially all studies now launching or moving forward, there is a push that they have some form of circulating tumor DNA assessment. Now, the challenge is, as a field, we have not agreed as to what's the preferred assay. So oftentimes samples are being collected and then stored until a later time point and then batched, meaning once you decide what's your preferred assay, then they're run all at once. So we're not getting that information in real time on those patients who are on those trials to know what to do. But just like I showed you, once those studies are mature and we see years of follow-up, then you start to see the MRD data presented.
Thank you. I think we have some time for just like 2 more questions here. Is there any data using MRD for marginal zone lymphoma?
There will be, but as of right now, because it's much less common than the other histologies, not robust data to show.
Similarly, what about MRD and utilization of PCR on T-cell lymphomas? This participant has AITL and has heard that autologous transplant really doesn't work. Relapse occurs. Is that because of ctDNA?
Actually, a really good question. And that's one area that is lagging behind, though there are a number of centers that are looking into this. Washington University with Dr. Neha Mehta Shah is partnered with Dana-Farber, and the Stanford group, who has done a lot of this work in large cell lymphoma, are all looking at this. There are actually unique challenges to T cell lymphoma, probably because it's even more diseases than B cell lymphoma. And so as of right now, there's not circulating tumor DNA assays that are clearly moving forward or the obvious choice, but I suspect that we will eventually have them. We just need to know more about the biology of all the distinct T cell lymphomas and what mutations to track over time. Why the outcomes are less good with T cell lymphoma, and it's across the board, not just AITL, but essentially all T cell lymphomas, is because it's such a rare entity. We don't do as good a job studying it. That's why organizations like LRF are critically important, because we need to pool all our resources. We need everybody to work together and do multi-center studies and really interrogate the biology of the tumor, because this is a scenario where we've been essentially applying the principles we learned in B-cell lymphoma for years. And maybe we should just throw out the cookbook and start over, but it's just so rare. It's hard to do that when you're working at individual centers.
Thank you so much, Dr. Nastapol. And I want to thank all of our attendees today for joining us and for asking great questions. I'd like to also once again thank our sponsors, Adaptive, Genentech, and Lilly, again for making this program possible. Please remember, if you have any additional questions, I know we couldn't get to every question here today, please reach out to LRF's helpline at 800-500-9976. You can also email us at helpline@lymphoma.org. But with that, thank you again, Dr. Nastapol, for your time today.
Thank you. Have a good day.
Have a great day, everyone.